Okay, let's start with today, which is what's new. Because we had a clinical practice guideline for schizophrenia 5 years ago, about 6 years ago. And this is the second clinical practice guidelines for schizophrenia that we launched. So I wanted to touch base on more about what new has been happening in the past 5 years in the management of patients with schizophrenia. But there are some things that haven't really changed. Schizophrenia still is a major mental illness that affects every part of our mind. It affects our thinking, our behavior, our perception, our emotions. So it affects every part. It's an incapacitating brain disease that starts very early. It strikes the young people in their early teens or early 20s, and it is a chronic mental illness. And it has a high cost in terms of direct patient care, in terms of dollars and cents needed to treat, the medications, hospitalization days, etc., as well as the indirect cost comes from the disability and the days lost of work. But we have made great progress in the treatment of schizophrenia. And then today we look more beyond. We just don't look at stability or maintaining just treatments getting better. What we really focus on is improving the quality of life of our patients and getting them to function better and recover from their illness, reintegrate back into the community. That's our goal today in the treatment of schizophrenia. Medications have remained the mainstay of treatment for schizophrenia, and we have come a long way since the 1950s when they discovered the first antipsychotic medication. Chlorpromazine was the one, and that kind of changed completely the face of psychiatry, where people were unshackled from their mental asylums, and it led a wave of deinstitutionalization, really relooking at the way we treat schizophrenia. And then we had the newer generation of medications coming in to the market somewhere in the late 80s and 90s. And there were a whole slew of atypical medications that we have in our armamentarium today. When they started being launched by the drug companies, there was a great deal of optimism that these were really going to focus on the negative symptoms, improve functionality a great deal, improve cognitive functions. And although they were much more expensive, we were very, very optimistic about their effects. And I think a lot of us thought that they were going to cure schizophrenia completely. But much to our disappointment, not disappointment, but rather I think it is a reality check for us. In the past 5 years, there have been 3 major studies which have come out of the US, UK, and Europe, which have really questioned whether the atypicals are all that, are they kind of really going to cure schizophrenia completely? Are they that superior to the typical antipsychotics? The first study, which was published in the New England Journal of Medicine, it came up, I think, in the year 2005. And this was the first multi-centered, non-drug pharmaceutical-sponsored study which looked at the effectiveness and compared the two. And they found really that the major finding was that there was not much difference between the two. And another surprising factor was that 74% of the patients discontinued treatment at some point during the trial. So it was hard to look at effectiveness when people were discontinuing treatment so often. Similar findings came out of UK. This was the Cutlass study, which again tried to compare these two medications in terms of quality of life. And again, the major finding was that these two were not very different, which led to an editorial in the British Journal of Psychiatry, Katie and Cutlass, Can We Handle the Truth? So they said that our conclusion must be that the first generation drugs, if carefully prescribed, are as good as a second generation drug in many, if not most patients with schizophrenia. So this is good news as it increases the range of choices of antipsychotic drugs, and careful prescribing of first-generation antipsychotics means using lower doses than was often done in the past. And clozapine clearly remains an important drug where others have failed. Clozapine is a medication that we use for treatment-resistant schizophrenia. And later on, my colleague Chailing was going to talk about the whole medication algorithm, where she'll talk about the effectiveness of clozapine in really treating treatment-resistant schizophrenia. A similar study came in patients with first episode psychosis, again published in Lancet. Now, we recognize that patients who have first episode psychosis are a bit different from patients with chronic schizophrenia. They are more sensitive to medications, and we thought that maybe they might respond differently than the patients with chronic schizophrenia. But again, the same thing happened even in patients with first episode psychosis, where we could not conclude that the second generation drugs were more efficacious than the first generation when they compared second generation with haloperidol. Again, because discontinuation rates were quite high. So the conclusion from all these studies were that it is not that the second generation were like really a magic pill that were going to cure schizophrenia. They were as effective as the first generation. And a lot of our patients didn't like taking medications. They discontinued treatment. So we had to work harder at engaging the patients. Other new findings came out with the second generation. And this, I've put this slide because, we started talking about metabolic syndrome. With the new medications, the atypical medications, we found that they were more prone to causing obesity, dyslipidemia, diabetes, and there were the more increased chances of them getting cardiovascular diseases. And that's why the American Psychiatric Association and the American Diabetic Association came up with a monitoring plan for all patients who were put on second-generation antipsychotic medications. So the moral of the story is we have medications which are effective. They still are the mainstay of medications. We have a wide choice of medications which are good and effective. They have some side effects which need to be monitored carefully. But what also we learn is that besides medication, we also have psychosocial treatments for schizophrenia. And the best way to go forward is to integrate the two, combine our medications with psychosocial treatments. We had allied health professionals from OT, social work, psychologists, all working in the schizophrenia work group. And over here, the next few slides, I'm really going to briefly summarize hours of their research and their input and their recommendations. So let's start with family interventions. Most of our patients in Singapore live with their families as opposed to in Western countries. So families can be an important partners in our care of patients with schizophrenia. And that's why we recommend that family intervention in the area of psychoeducation, telling them about the illness, roping them in the care of their loved one, has consistently shown to reduce relapse rate. The family intervention can be done in a group setting or one-to-one setting. More recently, sometimes when families are dysfunctional because they are broken homes, patients come from broken homes, or different families have different agendas, a form of therapy called systemic family therapy has been shown to be effective in improving clinical course and making sure patients comply with their medications better.